take place in the African region. Our hopes and goal are for all governments and international organizations to recognize our collective responsibility and intensify efforts to ensure that both adults and children do not endure untreated pain. Belgium has also pledged to invest in improving the availability of data and information concerning the medical needs and unmet gaps in accessing appropriate pain management, medicine, and care, with specific focus on pediatrics in the Democratic Republic of Congo. We firmly believe that evidence-based policy starts with reliable data. Therefore, with support of Belgium, the research team comprising members of the DRC and the Institute of Tropical Medicine in Antwerp will conduct a study to enhance our understanding of the barriers encountered by children and adolescents in accessing pain management treatments. The research will address all dimensions of access, including availability, acceptability, affordability, accessibility, and appropriate use of essential opioids in children and adolescents. Additionally, the study will also provide insights into the quality of medicines found at hospitals. For many years, Belgium has been advocating for increased awareness and action on the topic, and we are committed to continuing these efforts from our end. The site event is the perfect start of the regular session of the 67 CND, in which Belgium will also be leading the negotiations of resolution entitled Improving Access to the Availability of Controlled Substances for Medical Purposes, including for the treatment of children in pain through the promotion of awareness raising, training, and data collection. The resolution is tabled by the EU and its member states in partnership with Côte d'Ivoire. With this resolution, we want to encourage member states as they assess, develop, and implement policies to improve access to and availability of controlled substances for medical and scientific purposes to also consider the specific needs of children. I express my gratitude to the International Association of Hospice and Palliative Care for organizing this event, as well as to all speakers present today for their strong support. Thank you.
Thank you, Charlotte. And first of all, I'd like to thank our sponsors, which are up on that first slide. The Kingdom of Belgium, of course, the INCB, the Vienna NGO Committee on Drugs, the UN Office of Drugs and Crime, the Union of International Cancer Control, Dianova, and who have I missed? The Worldwide Hospice and Palliative Care Association and Pallium India. So huge shout out to Belgium and to Ghana for taking the pledge for action already to improve availability. And you just heard what Belgium has pledged to do. So let's hope that some other governments decide to join them throughout the year, because I think they can still join informally. And we will, of course, still support them. And this side event is about how we can support them and showing how civil society and academia and the UN secretariats that are involved can be key informants of member states. Next slide, please. So first of all, click, I think you can click again. There we go. Just keep clicking. What is the International Association for Hospice and Palliative Care? That's who I represent as the Senior Advocacy and Partnerships Director. We're a global membership organization where the red dots are, and that's actually a screenshot from a few weeks ago. It changes most of the time, but you can see that's where, those are the countries where we have members, more than 1,000 practitioners in 120 countries. We have 4 pillars of work: education, we have courses online for practitioners, we do research, information dissemination, and then there's my job, which is mostly advocacy for controlled medicines at the international organizations. Your next slide, please. So my idea for a healthy drug policy ecosystem, rather than staying in our own lanes or in our own silos, is that we have rational policies that integrate prevention, treatment, rehabilitation, and availability, rather than just emphasizing one, because only with rational policies can we really dismantle the stigma, which is irrational, which has been adhering to availability of controlled medicines before there was evidence and research and 2 decades essentially of practice to see what works and what doesn't work. And obviously we want safe availability, which does not allow for medical misuse or diversion that's going to cause public health harms. We need a trained and confident, and I would add ethical primary care workforce that can confidently prescribe rational amounts and evidence-based, of course. And we also need a regulatory and supply chain workforce that's well-trained, because often that's a missing and weak link. And then one of the things that INCB and WHO and UNODC have promoted is regional manufacturing, which we saw we really needed during COVID, and pooled procurement of generics rather than marketing of the expensive brand name opioids, which of course are more profitable for the pharmaceutical industry. Next slide. So I'm just going to briefly go through the order of speakers and then introduce each one. We have Dr. Cesar Thomas Arce from the INCB, the second vice president, Maria Goretti Loglo from IDPC from Ghana, Anthony Esposto, did I get it right? Esposti, sorry, from CAPSA in Canada. Heloisa Borgiato, who's going to join us from China, but she's originally from and done her research in Brazil. Pablo Estrella Porter from Ecuador, from the World Medical Association, Young Doctors, and of course, Elizabeth Simons from UNODC. So those are our panelists. Take a quick look at that, and then I'm going to pass to Dr. Arce for his presentation. So thank you for joining us, Dr. Arce.
Thank you. Madam Chair, fellow panelists, Excellencies, ladies and gentlemen. For a half century ago, in adopting the 1961 and 1971 Convention, the international community made a commitment to ensure and not unduly restrict the ability of drugs considered indispensable for medical and scientific purposes. Since the publication of INCB's first report on ability of controlled substances for medical purposes in 1989, INCB has continually assessed and monitored the availability across the globe. Our latest ability report, the supplement to the 2022 INCB annual report, no patient left behind. Progress in ensuring adequate access to international control systems for medical and science purposes show that there remains a considerable regional imbalance in the availability of controlled substances globally. Such imbalance not only goes against the aim of the Drug Control Convention to promote the health and welfare of humankind, but also contradicts numerous human rights instruments relating to the right to health. As present in the 2023 annual report, data report to INCB confirmed the persistent disparity between regions in the consumption of opioid analgesics for the treatment of pain. Almost all sub-consumption is concentrated in Western Europe, North America, Australia, and New Zealand. Consumption levels in other regions are often not sufficient to meet the medical needs of the population. Also, there is evidence that a large number of countries may not be accurately reflecting in the reported demand the actual medical needs of their population, contributing to the disparity in ability. While low and middle income countries struggle to obtain affordable control systems, countries in North America continue to battle the dire consequence of the opiate overdose epidemic. When inadequate control contributes to the exponential increase in the prescription of highly potent opioids such as opioids and fentanyl, the result was enormous increase in overdose death and the number of people with opioid use disorder. There are multiple and structural challenges faced by many low and middle income countries, including the lack of reliable data on the prevalence of conditions that require controlled medicine, the lack of reliable data on supply and consumption chain to estimate the national requirement for controlled medicine, limited financial resources, and problem in procurement and sourcing. Affordability is another key concern of patients in the global south. As pointed out in our previous report, most of the morphine produced globally is converted into other drugs with higher profit margins, such as codeine for cow medicine, instead of being used for palliative care in low-income regions. There is no doubt that some progress has been made since 2019, when our shared commitment to ensure equitable access and national use of controlled substance was reaffirmed in the ministerial declaration. However, it is necessary to accelerate our effort in this regard to ensure that this goal is enshrined in all national drug control policies and practices. INCB recommends that government consider allocating sufficient resources to ensure the adequate availability of controlled substances and encourage countries to reduce pricing and production policies of medicine for low and middle-income countries. Furthermore, the board also invite countries to increase the amount of morphine destined to palliative care and give low and middle-income countries the possibility of purchasing affordable morphine instead of expensive synthetic opioids. When it comes to people who inject drugs, government and medical authorities should also consider using methadone and buprenorphine for the treatment of opioid dependence, given the scientific evidence indicating the effectiveness of opioid agonist therapy to reduce dependence on import and increase affordability of controlled substance. INCB also recommends the strengthening of national and/or regional production of pharmaceutical in their generic form, so that the cheaper procurement with shorter delivery time can be possible for more countries. There is an urgent need to increase the availability and access to opioid analgesics and to improve their prescription and use, especially in countries reporting inadequate level of consumption. INCB call for targeted public policy support by government, health system, and health professionals, society, the pharmaceutical industry, and the international community. Thank you.
Thank you very much, Dr. Arseni. Our presentations mirrored each other's recommendations. Our next speaker is Maria Logla from Ghana, representing the IDPC, I think. Maria Goretti is a lawyer, and she serves as the African consultant for the IDPC, International Drug Policy Consortium. She plays a pivotal role in spearheading IDPC's initiatives across the African region and is a champion of human rights and comprehensive drug policy reform in Africa, including through the model law. So the floor is yours, Maria.
Thank you very much, co-panelists. It's really a great honor to be here this morning as civil society to share some light in the work we've been doing in trying to advocate for access to essential medicine, bearing in mind the fact that the region is one of the areas where access to essential medicine is a challenge. And I bring to this discussion my own brief experience in this particular area, and as well as working with the West African Commission on Drugs, especially in the development of this model law, to try and encourage member states to use that as a framework in terms of revising their laws to address these challenges. 2019, I had this very painful experience, especially in terms of access to these essential medicines. I unfortunately had a very painful miscarriage, which was uncompleted, and I needed to go to the theater immediately. I was admitted at one of the hospitals in Ghana, and the hospital was actually looking for ketamine to administer to me so that I can go through the procedure. And over 3 hours, we could not get ketamine. Many calls were made to several hospitals to be able to get this for me. And eventually luck dawned on us, and I was able to go through the process. I'm sharing this experience just to show everybody the need of essential medicines and how lives are at risk when it comes to this particular important topic. And so as civil society, we have been trying to engage with governments, and I'm happy that to hear this morning that my country actually pledged to take the action around availability of essential medicines. And so as civil society, we thought it was important to continue to engage policymakers within the region, not just in Ghana alone, within the region, to see how we can improve this. And we have been doing so using the model drug law that was developed by the West African Commission on Drugs, that was put together by the late Kofi Annan. Because through their country engagements, one of the key things that came out strongly was that countries were really suffering, especially when it comes to access and availability of essential medicines for pain management. Now, if you look at this model drug law, it basically gives a framework or a template that can guide member states to be able to review or amend their laws to ensure that there are no unnecessary impediments in terms of making these available substances for pain management and medication. I will encourage many of you, if you can go online, you can find the model drug law in book in French and in English. You can take more look at it. And if you take the model drug law, a whole article on, whole chapter has been devoted in terms of how we can review or structure our laws to be able to make room for that. So the model drug law actually goes deeper to provide legislative provisions and commentary, bearing in mind the international control mechanisms that we have and our commitment, and making sure that we legislate laws that should be able to address these challenges that we are facing as a continent. It also reflects evidence of how effectively we can do this practically to address the challenges on the ground and provide concrete templates and some kind of omnibus, health-oriented provisions that can help us to structure this well. One important thing in this particular model drug law that I love so much is the fact that it encourages member states to try and constitute commissions, and also to commissions that can look at improving access to essential medicines that should be overseen by the Ministry of Health. And so it sort of encourages an interministerial coordination mechanisms within countries to allow us to be able to honestly see what our needs are and how we can improve around that. It also sort of creates a national drug strategy as to how we can help create a balance in terms of availability of access whilst preventing diversion of these for non-medical use. Now, it's also heartwarming to see that our regional bodies like the African Union is gradually taking very strong steps in trying to encourage member states in this direction. In the 2019-2023 plan of action, it actually recognized that there is that need in the region. And so in their objective 2, that was the focus of this particular plan of action, and encouraging member states that there is need for us to do something around access to essential medicine, because it plays a very critical role in the lives of these citizens. And so countries must pay close attention to that. And to do so, we need to be able to review the laws that have placed unnecessary impediments on the ways of accessing these substances. And so it's important as a region that we look at this issue, have an honest conversation, see where the challenges are, and try to plug these areas to make sure that we are able to make it available while preventing the diversion of these substances. I want to end here, and if there are questions, I would love to take them.
Thank you so much, Maria, and I wish we had, instead of 50 minutes, a whole day to discuss this, because it's so important and complex and interesting, and but we don't. So our next speaker is Anthony Esposti from Canada. He is the CEO of CAPSA and leads an accomplished team of educators, researchers, and policy experts, all informed by their lived experience in their work to dismantle and transform stigma and discrimination for people addressing their substance use health. So you have the floor.
Thank you, Catherine. Thank you, everyone, and thank you to all the organizers of this event. I think it's important to certainly, when addressing this issue, to recognize the socioeconomic issues that confront various countries in access to medicines. But I want to come to a point that Catherine brought up in her introduction about stigma and stigma's impact on the access to available medications. CAPSA does a lot of work around stigma. We looked for a definition of stigma when we first started our work in 2018, and no definitions of stigma really suited our purposes, so we made up our own. And so we define stigma as a set of deeply held false beliefs about a certain group or individuals that results in the discrimination and oppression of those people. And so there's a few things that are important to break down there. First of all, that these are deeply held beliefs, so they're very difficult to dislodge. But the good news is that they're false beliefs. So through education, we can begin dislodging these beliefs and work towards transforming stigma into compassion. And so we use the term stigma a lot, we hear the term stigma a lot, and it's beginning to lose its meaning, and that's why we talk about discrimination and oppression. Stigma is used to discriminate and oppress people. And so there's three levels of stigma. There's systemic stigma, societal stigma, and individual stigma. And it all starts, systemic stigma and individual stigma all starts with societal stigma. It's people's attitudes towards others that create systems of care that are stigmatizing and create barriers to care for people and barriers to access to important and essential medicines. And then when I'm an individual with lived experience approaching these systems of care and encounter this discrimination, I begin to internalize that stigma. And it leads to decreased self-efficacy. It results in self-deprecation and feeling unworthy of care. Only 1 in 10 people in need of care for a substance use disorder ever approach a door for help, because they know that on the other side of that door, they will face negative attitudes towards their health condition, stigma, and discrimination. So we're looking to transform that into compassion. And one of the methods we are utilizing is CAPSA created a spectrum of substance use health. When we talk about substance use health, the focus has always been on the far end of the spectrum of use, and that's a substance use disorder. It's an illness model. That did not serve the mental health field at all. When you just focus on illness, there's very little service and information for people to address their health around substances. So our spectrum elongates that spectrum of use from no use, people who choose not to use substances for whatever reason, cultural, social, some people no longer use substances, to lower risk or to beneficial risk, so using substances as medication or for or even for ceremonial purposes in some cultures. Then there's lower risk use. There's use where consequences are beginning to be experienced, but outside of a substance use disorder. So social and health consequences to your substance use are being experienced. So the thing is that there's no information, there's no evidence-based information, no services, no resources for anyone outside of a substance use disorder to address their substance use health. So when we start talking about health, we can begin dismantling this stigma, this discrimination, when you want to address your health around your substance use. We talk about mental health and substance use care. Well, what is mental health and substance use services? Well, what are substance use services? Substance use services are your local cannabis shop, your corner drug dealer, your alcohol shop. Those are substance use services, and it has nothing to do with health. So what are the substance use healthcare services out there? And so when addressing the availability of medications, it's very important to begin expanding this conversation about health, because that's what we're talking about, addressing people's health, not addressing their substance use. And with that, I will stop there.
Oh, that was very interesting. Thank you, Anthony. That was a really useful addition to the conversation, because as we know, the fear is that people who need controlled medicines for their health and well-being will misuse them, and that there will be a public health crisis. And so you really filled an important gap. Our next speaker is joining us from China online, Dr. Heloisa Broggiato, who's a colleague for many years. She holds a PhD in international relations from Swansea University in the International System at the Global Drug Policy Observatory, specializing in access to controlled medicines in Brazil. Currently, she works as a political analyst at the Embassy of Switzerland in China, focusing on health issues. And Heloisa, you have the floor, and I'm sorry you only have 5 minutes to talk about your interesting research, but go for it.
Thank you. Good morning, everyone in Vienna. It's good to see you in the room, and it's good to see you also online. I'm going to talk about the current situation of opioids consumption in Brazil. In 2023, the Brazilian government approved the National Palliative Care Plan. So we hope that this can help to improve the consumption of opioids in Brazil. This was a civil society victory, and it has been celebrated. So where does Brazil stand regarding consumption of opioids today? Today, the consumption is still low. It's about 8 to 10 milligrams of opioids per capita per year. A bit more, a bit less, but it's about that. And just to compare with a country with adequate consumption, in Germany, for instance, the opioid consumption is about 500 milligrams per capita per year. So it's big difference, and they are considered to have adequate consumption. In Brazil, 75% of the population relies solely on the public health system. So today, the consumption is low among people that use the public health system, and particularly among Black and Indigenous people, and for the population living in remote or violent areas. They are in risk of having no access to opioids. Or they have to make use of other channels, informal channels. I will give you a few examples. So I want to mention violent areas such as the favelas in Rio de Janeiro. I heard from, in my research, I heard from doctors working there that sometimes no prescriptions are needed. When the doctors go to see the patients in the favelas, the patient says, you just need to tell me the name of the medicine and the dosage, because I cannot get it from the pharmacy. I cannot get it from the hospital. So they ask drug traffickers living in the area to assist them when they need controlled medicines. And it's a legitimate use, and these are good quality medicines, and they get it quickly. And nobody asks where do they come from. So I know it happens not only in Brazil, but it's not yet documented in other countries. So this is to show that there is a gap in the health system in Brazil. And it's also a challenge for the international drug control system. There are other informal networks organized also by local churches, for instance, in Rio de Janeiro. These churches, they collect donations of medicines and redistribute them according to the needs of patients in the favelas or in urban areas, mostly in places where it's hard to get into the health system. And this kind of network works well and works through a WhatsApp group that connects all the churches, Catholic churches, and community leaders. This kind of networks are present also in several Brazilian cities. They're very informal, but they work well. So as I mentioned, São Paulo and Rio de Janeiro are the cities with better access to opioids. It's because the reference hospitals for cancer treatment are located in these centers. So São Paulo and Rio, they get half of the opioids that consumed in Brazil. The most common situation is that the patients start their treatment in these cities. They get their medicines and they go home. In many cases, they go to very distant states. They have to travel hours by plane. But when the medicine finishes, they are back in their hometown. They have no access anymore in the local health service. And then they have to rely on sometimes on a friend or someone that they know in the place they started the treatment to go get their medicines and send them by post. So this is a very unreliable and a very vulnerable situation for the patient. Also, there are the remote areas in the Amazon region where opioids do not reach patients. These are remote and violent areas because of illegal mining activity and drug trafficking as well. And opioids are simply not distributed in these areas, not even for 100 years sometimes. In Brazil, the low consumption of opioids.
I need to stop you.
Sorry.
I need to stop you. Sorry. Could you bring
No,
to a
it's okay.
close?
I'm about to finish. I want to conclude that, in Brazil, it's important to concentrate efforts to reduce the bureaucracy on controlled medicines regulations to allow them to be distributed equitably in primary health care. Thank you.
I'm really sorry to cut you off. We've only got 10 minutes and 2 more speakers. So thank you, Heloisa. That's so interesting and useful and shows that if with good regulations, we wouldn't have such parallel market the way we do, but at least they're organized in Brazil. So our next speaker is also from Latin America, originally from Ecuador, Dr. Pablo Estrella Porter, an Ecuadorian medical doctor currently in his third year of preventive medicine and public health residency in Spain. He serves as the membership director for the Junior Doctors Network of the World Medical Association and represents youth on international World Health Organization youth platforms focusing on antimicrobial resistance and alcohol policy. You have the floor. Thanks.
Thank you very much. So having this basis to discuss about the access to controlled medication is essential, especially when we're talking about pain management and palliative care. There are several barriers that prevent millions of patients, or can actually help millions of patients to avoid suffering with this medication. Some of these barriers include, first, the strict regulatory frameworks that there are. So, for example, there's some countries with overly restrictive or others with excessive tolerance regulations. Then the education of health professionals is part of the barriers. We do see that there's need of improvement both in medical schools as well as in the postgraduate training. The limited funding, as always, is key here on the access to essential medication. And as Anthony was speaking before, the stigmatization of the use of this medication, but as well on the prescribing itself. As junior doctors, we do play a key role in improving access to controlled medicines, especially because we work at a local, national, and an international level through the rational prescribing practices. So we need to find the sweet spot between achieving the desired therapeutic objectives while also being aware to address the risk of dependence of use of this medication. Then raising awareness, and not just with our patients, but with our peers. This is how we do create a network. Then overcoming diversion and non-medical use of medication, that's something that is happening every day. And finally, recognizing signs of dependency and contributing to patient monitoring. That's because we are on the first line. We are dealing with patients every day. So to address these barriers, we do need to work, as I was mentioning, engaging on medical education. That's because junior doctors were on the prime moment to deal with this. It's a great investment because basically it would have a long-lasting effect on our careers and our medical practice. Then to provide sufficient resources and establish proper regulations for pain management. We do need also to foster collaborations between the drug control regulators, but also including health professionals in these discussions as it's happening in this panel, and to address the stigma that is associated with controlled medicines. Coming back to my home country, Ecuador, I wanted to share also some of the experiences and what is happening in the country. So as many Latin American countries, we do have a huge difference on how private and public sector works. And we do see that these gaps fall under the availability of medications, but also to the access. Some people have a lot of issues, not just to access health professional service, which is already concerning, but to get a prescription itself. Therefore, we see that also demographics of countries such as Ecuador, comparing rural versus urban areas is an issue. Just 10% of all the pharmacies in the countries are located in rural areas, even though our population is about 30% of population in the rural areas. So we do see the difference. And even though just 13% of the medication officially is considered to be able to be sold over the counter, on the last research, it was shown that more than 75% of patients in Ecuador were able to access prescription medicine without a real prescription. So as it was discussed by my previous colleagues, we do see that patients do need to find a way through, especially when we are finding these issues. But all this problem is aggravated with one concerning topic, that is the quality and effectiveness of medication, where basically Ecuador have raised the flag that there's substandard and falsified medications that are going on the market. So we do need also to work on these issues. Finally, I want to use this platform to acknowledge the unique position that junior doctors have, and also to thank UNODC for creating this youth network of doctors, where we're trying also to push the future health leaders. So thank you so much, and yeah, really happy to be here.
Thanks, Pablo. That was great and really helpful. I look forward to more discussions, and you'll be speaking tomorrow on the floor, yeah, for agenda item 5. So our last speaker, last but not least, is Dr. Elizabeth Saenz, originally and always a pediatrician, originally from Venezuela, and the program officer at the UN Office of Drugs and Crime in the Department of Prevention, Treatment, and Rehabilitation, former liaison officer with WHO in Geneva. You have the floor.
Thank you, Catherine, for the introduction. Thank you to our panelists for our generous donor present here today in this program. I basically want to wrap up what everybody has said. I don't want to please the next repeat what we all know. But basically, you know, we all know what the commitment is. You know, it's about controlling substances, but beyond that, it's about ensuring that these substances are used for the noble purposes of healing people, yeah? So the situation we know, 80% of the people who need these medications don't get it. This year, we have a special emphasis on children because it's an invisibilized group that is in most need. Please, the next one. So we know which are the barriers to access to controlled medicines, the insufficient knowledge and training and the capacity of the professionals, the behaviors, the fear of abuse, of dependence, of diversion, but also the lack of adequate and accurate quantification of needs, because as you may all know, the control system ends at the last part of the smallest retail, meaning that once the patient gets the medication, we never know patient really used it or not. So there are still things to be done to accurately assess how much people really need. And of course, what everybody has mentioned here, which are the regulations. Next one, please. So I need the presentation, just otherwise you will, I will never stop talking. So the attitudes of doctors is one of the aspects, and therefore we established this network of young doctors. I think it's one of the most challenging ones, because as a medical doctor myself, I remember when I graduated, they gave me this booklet, and it was like giving me a K647 or a gun. Now, with this, you can kill people. And recently, we heard from a young doctor that in his country, the prescription itself is called poisons. Yeah. So how can a person that swears to devote his or her life to saving people, we swear that when we receive our title, prescribe a poison. So of course we don't. We avoid doing it. We don't want to do it. So how to change that, and also how to reassure doctors by means of addressing, for example, diversion, addressing non-medical use and misuse of of controlled substances for doctors to do their job and properly prescribe these medications. Next one. Next one, Lale. Okay. So how to keep balance? Because we talk a lot about balance, availability and access, and having adequate legislation. And we see the fears with which some member states defend, instead of opening up to the attitude that will enable, rather than, put always the balance on the side of a restrictive regulations. Next one. So in our program, this program was created in 2013. UNODC started working on this topic in 2011. I took over this program after coming back from Geneva, and I found a situation that was really, really appalling. First of all, because no money. So everybody says this is an important topic. Everybody acknowledges the work of UNODC. Everybody's calling for more action. But the reality is this program has only raised $1 million in 10 years. So in my previous life, I was coordinating drug treatment projects, and we were still complaining because UNODC, for your information, only gets 5% of the budget of UNODC goes to our overall health mandate. And that includes HIV prevention, treatment, and access to controlled medicine. So when for treatment in 10 years, we have maybe 30 million accumulated budget, and we still complain because that's too little also for treatment or for prevention. Here are my colleagues working on prevention, imagine for access to controlled medicines, 1 million in 10 years. That's nothing. And we are still very grateful to our donors, mostly Australia and Belgium, but it's not enough. So what we've done with a wonderful team of young professionals that accompany me in this program, we have opened the title of the program and said, okay, what can UNODC really do to address availability and access? But also we talk about preventing diversion. Are we really doing something? No. How can we reassure doctors, or like Eloisa mentioned, the connections between medicine theft, corruption in the health sector, organized crime within the health sector, and falsified medicines, because all those medicines that people buy outside the official are by definition falsified medications. How do we address all of that? So we've put that as a pillar of our program, preventing, detecting, and responding to diversion, not as a law enforcement thing, but as in the health system, how to identify what measures, including technology. Nowadays, technology and electronic systems can help a lot in preventing diversion. And of course, we have the other leg of our program, which is preventing non-medical use and misuse, because this could be an interesting proxy for countries to know how much of the medications that are needed to treat somebody in excruciating pain that is going to students to stay awake, or to people to use them for non-medical purposes. The next one. So just to finish, some of the innovations we have included in this program, and let me tell you, there is a lot of thinking behind, is first of all, the establishment of this network of young doctors. We are working with the Junior Doctors Associations. They have representations all over the world, and we have been overwhelmed by the positive response and the commitment of these young people. They are craving for this knowledge, and they are ready to disseminate it. So our plan is to equip the Young Doctors Associations around the world with this knowledge. What are the conventions? What are the legislations? What can they do from their point of view, from where they are, to help us in this quest? The second is enhancing or expanding the partnership that we have for 10 years with the World Health Organization and with INCB, and we have established an interagency working group on access to controlled medicines. And interestingly, we have found that, for example, UNIDO, the UN Industrial Development Agency, here in our building, they have a pharmaceutical industry development program that can help us to improve the production of controlled medicines in many countries. Also, they can work on traceability of medicines so that to prevent diversion. We have invited UNFPA because they are very interested in issues like access to controlled medicines in reproductive health. Women undergo excruciating, painfully procedures, fertility procedures, even in high-income countries, without any form of pain relief. And also intergovernmental organizations like African Union, the OASCCAT, they are also on board of this interagency group. So we are, again, working on developing the tools, because in 10 years, with $1 million, you cannot develop training packages, guidance documents. No, we need the funds to develop those tools so that we are able. And I'm telling you that this team of young people behind me, they are working as volunteers, helping us put together all these materials, and we will have them before the end of this year for sure. And of course, we, in addition to prevention and treatment, we want to address the needs of the most affected groups by non-medical use, which are the young university students, women, and this can be found in the World Drug Report, and the elderly. I just want to bring to your attention that the World Drug Report counts drug use until 64. Young people like me, we don't get in there. You see, after 65, you are done. So what happens with the elderly and non-medical use or misuse of controlled medicine? A lot. Imagine in nursing homes, elderly people are put on so that nobody gets bothered. Next. I think I'm done. Yeah, this is just to show you what we have, $1 million. These are the countries that we have been able to work, thanks to Belgium and Australia. There in blue, you see there have been some other interventions on this program, but with funding that has been channeled through regional programs, not necessarily the global program. And I think this is my last slide, please. Yes. Thank you very much for being with me.
Thank you, Elizabeth. That's very hopeful and inspiring. And thank you, everybody, for coming. And sorry we went over time, but you can tell how rich the content and discussion was. So thank you, panelists, sponsors, audience, everybody. Oh, that was great. Thank you. Sorry I put you at the end, but I knew people would stay to listen to you.